No, me. I'm going first.
Sorry.
So I was invited to share a little bit on the Jewish perspective on MAID. And I want to say that I had the very, very meaningful experience to be part of a committee of rabbis that wrote on this topic recently. Some of you are aware of the responsa literature that's part of Jewish tradition, really going back through the centuries, in which a rabbi is asked a question. It's like a case study, and the rabbi will respond in writing with what a Jewish perspective is on a particular issue. In modern times, in the different movements within Judaism, there are responsa committees that field these questions and respond by committee. And I'm a member of the Reform Rabbis Responsa Committee. So we were asked this question: may a Jew opt for physician-assisted death in jurisdictions where civil law allows it? And may a Jewish medical practitioner assist a patient in dying? Now, it's interesting, this question was submitted by Rabbi Larry Englander of Mississauga. Some of you might know Rabbi Englander. And it was a question that was submitted because it was really only in Canada where this question was an active question and not a theoretical one. And so the CCAR came up with this response. If you're very interested, I made some copies. It's very long and very small print, but I'm happy to share if anyone would like one after the program. But I want to share a couple of things from it, and mostly really kind of end with the tachlis, which is, how do you translate tachlis? Like the main idea, right? What do you actually do with this information? The bottom line. Thank you, Rabbi. So it's first of all important to recognize that almost all halachic precedents prior to the modern era have rejected the idea of assisting a person with dying. And actually, the Reform movement committed itself to that same stance in 1994. A similar question was asked when this started appearing in Europe. And still, the Response Committee thought it was important to revisit the issue, partially because of MAID in Canada, but also the ways that things evolve in our thinking and understanding. And that's part of responsa literature in general, is that times change, things evolve, and it's important to continually engage with this topic. So one of the important ideas was, first of all, thinking like in historical context about illness and death, that in most of our traditional writings, the way that we think about a term of illness and death was very close together. There's a text that talks about usually that being within maybe 3 weeks, that more than 3 weeks of suffering with an illness that was a fatal illness would have been really unheard of, that the time in which our modern medicine is able to keep people living, even with debilitating or serious illness, has extended greatly in recent years. And that was one consideration the committee made. Another important idea from Jewish tradition is about the importance of easing suffering, and that compassion to be able to alleviate suffering is a very important Jewish value. And the notion that someone's death might actually alleviate suffering is part of Jewish tradition, or that, I should say, extending a life unnecessarily is a way that might bring about unnecessary suffering. So one story that's a very famous story from the Talmud talks about the rabbi's belief that prayer had the power to keep someone alive longer or also cause their death, which is a very interesting theological concept. And that sometimes there are times when it's appropriate to stop praying for someone to live, that there is a time when we want to allow the person who is suffering and dying in the space that is required to allow them to let go, so to speak. So the one story I want to share today comes from the Talmud. It's a story about the death of Rabbi Yehuda HaNasi. He was one of the most famous rabbis of our tradition, that he fell gravely ill. And when that happened, the sages, the other rabbis around, said that they had to declare a public fast and pray for the rabbi to not die, that he was very close to death, and they wanted to bring all of their prayers together to make sure that he wouldn't die. And the rabbi's maidservant, his helper, actually went up to the roof of the house, and she said, "The upper realms, that is the angels and God, want the rabbi," meaning that he's ready to die and they want his soul. "And the lower realms, the humans, the other rabbis in the house, they want him. They're praying so much that they're keeping him down on earth." And the maidservant said, "May it be your will that the lower ones will defeat the upper ones." Meaning, she said, I want the rabbis to save him. I hope that they'll be able to do that. But then she saw how many times, it says he had to go out to the privy and remove his tefillin and then put them back on each time, and how it caused him to suffer. She saw his suffering. And she said, "May it be your will that the upper realms defeat the lower ones." So she prayed that God and the angels would take the rabbi. But the rabbis didn't stop praying. Their prayers were so powerful, they kept praying for Rabbi Yehuda Nasi, and they kept him alive. So what did she do? She took a pitcher and threw it from the roof to the ground. And it caused the rabbis to stop their prayers. They fell silent, and Rabbi Yehuda Nasi died. So it's a very powerful story about the power of prayer and also the space sometimes that is required for someone to actually die. It's important to remember that in Judaism, our halakha, our Jewish law, values life. And this is really significant. And we value the practice of medicine to preserve life, wherever that is possible. So let me get to the tachlis, the bottom line. The conclusions of the Reform Responsa Committee are this. We agree in principle that in an era in which medical technology can prolong life to the point that a person's existence becomes torture to them, when refuat haguf, that is the healing of the body, is no longer possible, we can at least support the choices of those individuals for whom death is refuat hanefesh, the healing of the soul. And then it goes on with 4 basic points. A Jew suffering from a terminal illness whose death is not imminent, where it is legal, may avail themselves of physician-assisted dying under the following circumstances. A, the patient has full and unlimited access to all effective medical care necessary for enabling them to live a meaningful life so far as they are able. B, the patient and their legal heirs have made formal attestation that financial considerations have played no role in this decision. So the committee was very concerned about the ethics of people choosing MAID so as not to be a financial burden on their family. And C, the patient has undergone careful screening by a trained committee of professionals to ensure that the motivation is not untreated depression. So very concerned that this was not for mental health situations. So that was point 1. 2, a Jew suffering from a debilitating chronic illness that is not inherently fatal may choose to avail themselves of physician-assisted dying as a last resort if living with the degree of suffering they must endure is intolerable, subject to the criteria stipulated above. 3, a Jew suffering from mental illness, but not a terminal illness or chronic and debilitating illness, may not avail themselves of physician-assisted dying, since we cannot properly evaluate their state of mind. And then finally, 4, a Jewish physician who recognizes that a suffering individual has a terminal or incurable condition that has placed them in a state of what palliative medicine refers to as total pain, may respond to the sufferer's desire to end their suffering by administering or making available drugs that will terminate the individual's life, subject to the stipulations above. So that is the response to the question about a Jewish physician. So there's obviously much more nuance and discussion in these 14 pages of small print, but I think you can see that the committee, as I think society generally has broadened and shifted some thinking around this topic. So I will turn it over to Rabbi Bregman.
Thank you. I'm going to stand. First of all, you should know I'm the Father, not the Son. And our wife is the Holy Spirit. Thank you. How many of you have pets? or have had pets? Okay, so the world is divided into those who have had and those who haven't. I think you would probably understand what I'm talking about in terms of the compassion that we show for our pets. And so the call came to me from a congregant, and I had a very long experience with this individual and the family. Would I come and see this individual in the hospital? I had known about the individual's illness and had heard from other family members that this was not getting better. And so I went to the hospital and I met with the individual and family. And I listened very carefully. And I was told that the individual has chosen the route of MAID, medical assistance in dying, and had the interviews and was now just scheduling the time. The individual, and I confirmed this with the doctor, was going to die, and it was not going to be a pleasant death. And the person was concerned, having seen a parent go this way, that they did not want to experience the same thing. And then said, would I be present with the immediate family when the doctor came in to administer the drugs? And I said yes. And I arrived at the hospital. Doctor came in, introduced herself, and I then spent a moment with the doctor privately and said, before you administer the drugs, would you please have eye contact with me? There is a prayer that is going to be said. And the doctor said, absolutely. And so the time came, and the doctor came in again. The IV was already in the arm, in the hand. And the doctor looked up and looked at me. And with that, the patient and the family recited the Shema. Those 6 words that really, in essence, summarize a great deal of who and what we are, not only from a theological point of view, but from a historical point of view, and so on. Hearken, listen, Adonai. The Lord is one. Listen, Israel. And with that, the individual then turned to the individual members of her family and expressed her love. And then the doctor took the patient's hand, held it, and then she bowed her head for a moment, and then proceeded to administer the drugs. It was an incredibly holy moment. When the patient had died, I made my way out of the room. I had already informed the Jewish funeral director that this was going on, but now please send someone to retrieve the body. and then went to the head nurse and said, "The patient has died. Please do not remove the body from the room. The family will be remaining in the room until members of the Jewish Burial Society will arrive." And the nurse said, "Absolutely." And at that point, I caught a glimpse of the doctor. And I went up to the doctor and I said, "Thank you. I know I'm not supposed to ask this, but are you of any specific religious tradition?" And she said, "No, I'm really not religious." I said, "You may not be religious, but you are one of the most spiritual individuals I have ever encountered." And so when Cantor Cohen asked me a number of weeks ago, did I know an appropriate speaker to come and speak to us, the answer was absolutely. Ladies and gentlemen, Dr. Jyothi Jayaraman of MAID.
Thank you. I'm going to be standing as well. I just can't sit and speak, so I hope you can hear me.
You just
You're
hold
too
it close
kind.
to your mouth.
Can you hear me?
Hold
Yes.
it very close.
Hold it very close. Can you hear me now?
Yes.
Yeah. Thank you so much to you, Rabbi, for inviting me to speak here. He is too kind. It was a very profound experience for me as well. My talk is going to be a little drier, I think. I'm not sure, though. Maybe yours was not too. After him,
I know.
So
I had him go after me.
Okay, but now I have to go after him. So I was asked really to speak about MAID and the nuts and bolts of it. So pardon me if it's a little dry. I'll try to make it a little interesting. So MAID became legal in the rest of Canada, and I say rest of Canada because Quebec did it differently. It became legal in Quebec in December of 2015. In Canada, in the rest of Canada, it was June of 2016 when it became legal. Health Canada published its latest report, which ends with 2023, and we've had approximately 60,000 deaths due to MAID from 2016 to 2023. And that in 2023 itself, it's about 4.7% of total deaths have been due to MAID. In British Columbia, it's a little more than that. It may be closer to 6% in 2023 and perhaps even higher in 2024. The males and females are approximately evenly distributed. 51% in 2023 were men and 49 women. The median age was around 77, and the majority of cases, which were the people who asked for MAID, had cancer. I'm going to start by talking about a hypothetical case. This is Anna, and she's in her 60s. She has ovarian cancer. She's had it for 3 years. She had chemotherapy, surgery, chemotherapy, loving husband, children are there, very well supported. But she's now reached the stage where she has a lot of fluid in her abdomen. Even though they drain it, she has a lot of pain. She is suffering a lot. She's almost always confined to bed. And she's moved into the palliative care unit where they're doing their best to make her comfortable. But she's just not comfortable anymore. So she asks for MAID. How does the MAID process begin? This may not be unfamiliar to some of you, but I thought it's worth describing it a little bit. So there is a formal MAID application that one has to make. It's freely available. If you just Google, or someone in your family Googles BC MAID forms, you'll arrive at that website where the form is. It also gives details on how exactly to complete the form, but there are also phone numbers to to the respective health authorities. And if you have any doubt, I advise you to pick up the phone and call them, because they are very helpful and will assist you in advising you about who is an independent witness, who can be a proxy. And these are important because this is a legal matter. So this form has to be completed properly, otherwise you'll be asked to do it again.
Sorry to interrupt. There's a request to even closer to.
Oh my goodness, okay. As long as I'm not echoing. Oh, sorry. If you don't mind, if you're here till dinner time, then it's okay, right? If I speak any slower. Okay. Is this better? Yes. Okay. Gosh, I feel like I'm echoing. Yes. So once the form is completed, it has to be sent to the coordinator at the assisted dying program, and they will allot it to assessors. It has to be 2 independent assessors, and for example, someone like me, they give it to us. They do some preliminary homework, they contact the family, they find out some details. So what does the eligibility look like? What are the criteria for eligibility? In Canada, you have to be 18 years or older, and you must have capacity. This is important. You must be eligible for publicly funded healthcare services. So unlike Switzerland, we don't have MAID tourism in Canada. It must be a voluntary request with no signs of external pressure. This is something that we have to ascertain as assessors. And you must give informed consent. This is actually a very important point, because informed consent is actually required for anything. Whether it is chemotherapy, whether it's a surgery, informed consent is required. And what does it mean? It means that you are aware of your alternatives. You are informed of your choices, and you decide to choose one particular option, and then you have to say why you are choosing that option. That is informed consent. You must have a serious and incurable illness. As of now, mental illness alone, exclusively mental illness, does not qualify. You must be in an advanced state of irreversible decline in capability, and you must have an enduring and intolerable physical or psychological suffering, which cannot be reversed or improved by means acceptable to you. This is an important point. Acceptable to you. In Canada, we have the right to refuse treatment. So it's not based on can it be reversed, but is that method acceptable to you? Now, one of the most important things to remember is that a MAID request can be withdrawn. It can be withdrawn up to the moment that first medication is given. And that moment is when the provider, the person who actually does the procedure, we call ourselves the MAID providers. So the provider will actually talk to the patient and say, I am Dr. Jyothi, and I'm going to give you this medication. It is going to end your life. This is no time for euphemisms. We are very direct. This is going to end your life. Do you want me to do this? And unless they say yes, now it doesn't have to be verbal, because sometimes people are very ill or they have a disease like ALS. They cannot actually say yes, but they may nod, they may blink with an eyelid, and that's good enough. But unless they give that final consent, we cannot proceed. That's called the final consent. So what happens, you wonder, if somebody has a stroke suddenly, somebody has a fall and has a hemorrhage, they become unconscious. They're heavily sedated because they're suffering so much that they've received a lot of medication. What happens then? So the law that was passed in 2016 was amended in 2021. And we have what's called the waiver of final consent. Now that is an agreement that is signed between the MAID provider and the patient. It's usually done at the time of assessments. And what does it say? It says, if I lose capacity to consent before my MAID provision, I want you to proceed with MAID. That is the agreement between the patient and the provider. What is the role of the substitute decision maker here? What is the role of the family here? Their role and responsibility is to honor their loved one's wishes. They contact the provider and say that the circumstances which you agreed about have now arisen. It is not they who are making the decision to end the life of their loved one. This is important for everybody to understand. The loved one has said, I want to die if I have lost capacity. So you are only calling the provider and saying, my mother or father or whoever it is has lost capacity, can you come? So that is called the waiver of final consent. It is really important to understand that this is meant for acute events. You have a stroke, you fall down, you hurt your head, or in a terminal delirium, you're sedated. It is very, very difficult to implement a waiver when someone has dementia. We are often asked about this, but it's difficult to do it. There is something called the advance request for MAID that maybe some of you have seen it. Right now, it's legal in Quebec. It's not legal in the rest of Canada. And the waiver of final consent is not an advance request. This is difficult to comprehend, and afterwards, if there are questions, I could elaborate a little bit. So I mentioned that cancer is one of the most common reasons to have MAID. But there's a second one, which I think is important to understand. It's frailty. So let me describe Bruce. He's 85. He has heart failure. He has COPD. He lives in a nursing home. He receives total care. He needs help to be moved to a wheelchair, help with meals and showers. And now he ends up in hospital with an exacerbation of his heart failure or COPD. They help him, he feels a bit better, but at the end of a week, he's not that much better, and the team has a goals of care conversation with him. And they ask him, what does he really want? And he says, I want to go back home, which is my nursing home, and I never, ever, ever want to come back to the hospital. And so he returns home and fully expects that now that he no longer wants to go to hospital, he's just going to die. But he doesn't. 3 months later, he's still alive, and this is his life, and he's done with it. So he applies for MAID. He's got a daughter. She's his only living relative. She adores him, and we'll talk a little bit more about her later. So why is frailty such a crucial issue? Because people who are frail, first of all, how do we recognize it? They are more frail in terms of they're fatigued easily. You know, the person who is to enjoy being taken out for meals, for a little bit of shopping, none of that. They just want to lie in bed or sit in the nursing home or at home. They don't want to come out. If they walk with the walker, they're walking really slowly. They've lost weight. Sometimes they don't, it's not obvious, but they've lost a lot of muscle mass. And why is frailty so important? Because mortality is higher the frailer you are. The other reason is some aggressive interventions actually have a very poor outcome when the person is frail. So for instance, a very frail person going into the ICU can have prolonged delirium, or they can emerge with their cognition less intact. So it's important to know whether someone is very frail, and it's important to have goals of care conversation. If the doctor doesn't have it with you, you need to raise it with them. And by goals of care, I mean, do you have a do not resuscitate document completed? Because again, being resuscitated when you're very frail, the outcome is probably going to be very poor. There are also levels of intervention. You can opt not to be transferred to ICU, for instance. I'm mentioning this because I often go in as an assessor for someone who said, I want MAID. But when I ask them, do you have a do not resuscitate document completed? What is the level of intervention you want? And they have no idea. So they've jumped all the way there. So there are lots of opportunities for a natural, peaceful death. And, you know, it is something that people can take advantage of if they wish to. So what are some of the challenges I've seen? I mentioned the daughter, Bruce's daughter. Family dynamics are really important with MAID. Interestingly, although what we are on the lookout for is coercion in terms of is anyone being forced to apply for MAID? We'd never want to see that. But actually what I have witnessed is the reverse. I see a lot of pressure put on patients to not go through with MAID. It could be out of love, it could be out of societal reasons or religion, something, but that's what I see. So family dynamics can be tricky. Sometimes it's just an excess of attachment, and how do we support that? Another thing is capacity, especially when you're dealing with frail people or people with dementia, and I'll be talking about dementia in a minute. But how do we assess capacity in someone like that? Again, the providers, we are responsible for talking to their loved ones, talking to the staff in a nursing home, and saying, when is the optimal time? Sometimes I've had to go in more than once. The first time I go, the person's unable to communicate anything. But then hearing from the loved ones or the staff, no, they're usually better than this, I will go back. So capacity can be challenging at times. And finally, I'd like to mention a term, it's called forced transfers. What is that? It is that when a person is in a facility or in a hospital, an acute care or a long-term care facility, depending on the organization which is running it, some of them will not permit MAID on the premises. What this results in is very vulnerable, frail people at the end of life, often on infusions of fentanyl or something, having to be transported, often by ambulance, to some other location just because they are not, the institution doesn't allow them to have MAID in their own bed. That's called a forced transfer. I said I'd speak a little bit about dementia. Many people may not be aware that people with dementia can actually apply for MAID, and this has been true right from the beginning. Even in 2016, you could do this. There are challenges to applying when someone has been diagnosed with dementia. It depends on the stage of dementia that they're at. Because one of the things that happens is the loss of time awareness, a loss of the ability to time travel, meaning I can't really project into the future anymore, and I'm beginning to lose sight of the past. With that loss comes an inability to plan for the future. Today becomes so important and so big that you don't think about tomorrow at all. So I have a painful task. When I evaluate a person with dementia, I describe that there is a window of opportunity. Right now, you recognize what can happen as dementia advances, and it may be that you have a small amount of time when you can actually act to have MAID, because you will soon arrive at a point, and I don't know when that is, but you will arrive there where it's not going to matter anymore. And so sometimes people feel that those with dementia who've had MAID end up having it sooner than they might want. What about the waiver of final consent? Why doesn't that apply? Because the capacity loss in dementia is not a one-off. With a stroke or with a brain hemorrhage, when the brain is almost dead, there's no reversibility. With dementia, today, I might not recognize my daughter. 3 days later, I do. How do we know? How do we know that capacity has been lost? So I am very clear that using the waiver in dementia is very, very challenging. I've had to do it. I mean, I've been prepared to do it once, but as it happened, she rallied and she was able to say yes confidently. But I do warn people that it is not something that you want to depend on. When the advance requests become available, as it might, amongst us providers, we are filled with trepidation because people write things like, when I can no longer do this and when I can no longer do that. However, as a doctor, if I come and see you, I don't know that I can just say, well, you're no longer able to recognize all your family members, but you're enjoying karaoke, you're happy. How am I supposed to end your life? I don't know. So thankfully, I haven't been asked to do that yet. I'm very briefly, I don't know how much time I have, but I'm very briefly going to talk about track 1 versus track 2. Many of you may not even be aware of the existence of this. So when MAID was made legal in 2016, it was for people whose death was reasonably foreseeable. Importantly, it was not somebody who had a prognosis of 6 months or 1 year. We were not required to put a prognosis. It was somebody whose trajectory towards death had become clear. It could be even 5 years, but we knew that they were declining markedly, and so we didn't have to specify prognosis. But death had to be reasonably foreseeable. In 2021, the law was amended, and we now have a track 2, where death is not reasonably foreseeable, and that was mentioned by Carey, where you, well, let me just tell you a case again. So you have a 65-year-old woman, let's call her Rose, and she has osteoarthritis, severe, of a lot of different joints. She's had 2 hips replaced, but her knees are bothering her shoulder. She's in severe chronic pain. Everything's been tried. She's been to the pain clinic. She's had a multidisciplinary approach. She's well loved, well supported. She has home support coming in, and yet she is suffering. She's been using a walker, but now it looks like she's going to have to move to a wheelchair. So now she says, I want MAID. She could qualify under track 2. The distinction is that with track 1, in most cases, it's going to be, as soon as you're found eligible, you can set a date. With track 2, there's a 90-day assessment period where the assessors have to be really diligent, if necessary, talking to the experts, talking to the family doctor, making sure that everything that can be done has been at least offered to this patient. So it's a longer process. Also, the waiver of final consent does not apply. That's track 2. And finally, what is the procedure like? Again, for those of you who have been there, you've seen it, but there are actually 2 methods. There is the oral method and the intravenous method. Of the 60,000 or so MAID deaths in Canada, maybe less than a dozen have been through the oral route. This is because the medication is about half a cup. It can be bitter. You might be nauseated. You have to take medication to stop yourself throwing up. You may fall asleep in 5 minutes, 15 minutes. You may die in half an hour or 2 hours. There's so much unpredictability that we don't recommend the oral route at all. And in addition, unlike in the US, in Canada, even if you use the oral route, it's not something where the doctor signs a prescription and you take it to the pharmacy and off you go. Here, the doctor brings the oral medication to the house. We have to be present. So it's not, people talk about, I just want to go into the woods and die on my own. Not happening. Not here anyway. So the IV route, we use 3 medications. First of all, the date and time is set collaboratively. The patient or the family contacts the provider. We're all doing many different things, but we find the right time. And a nurse is involved, our own team nurse. They come, say, half an hour prior to the agreed time. I would arrive maybe 15 minutes beforehand. And then the nurse has placed the IV. There are 3 main medications that are used. If some may notice that there's an additional medication here and there, but the 3 basic ones. The first is a sedative. It takes about a minute or less, and the person goes to sleep. The second one is a coma-inducing agent, and the person usually passes away during this time. At least they stop breathing. Sometimes there's a bigger sigh or a little snore. Nothing to be alarmed about. It's still peaceful. The final medication is a paralytic agent. It just paralyzes everything. It's probably not even necessary, but we do use it to make sure. And that is, it takes, the whole thing maybe takes about 6 minutes. and it's very peaceful. I've had children as young as 7 and 6 be present. Of course, we've warned them and told them what's going to happen, but it is really peaceful. Are there some rituals around MAID? Yes, most of the time, I would say the one common thing has been music. Almost everybody has a song that they would love to listen to, and I encourage that. It provides solace to the family and to me, too. So there is often music. Sometimes these days they have a pre-celebration of life. People who say, I want to know what you're going to say about me now. And so they have that. And sometimes there is spirituality. It can be, with a rabbi or the different denominations, maybe from the church or a spiritual counselor. They could be present in person. Sometimes the patient has received something like communion or a blessing beforehand, and they have prayers and chanting during. The family may do it, or they play some kind of thing. And so in some cases, it's very simple. I've done some where it's the patient, it's the nurse, it's me, and their dog. And the dog is there to provide comfort, and that's what it is. That's what was most meaningful to them. On the other hand, there was one, she was 101 years old, and she had 55 extended family members present. It was a tea party, and she went out in style. So it doesn't matter. It's what the person needs. What do? We have to draw up our own medications, and that takes about 15 minutes. I've made it a practice to put on some music of my own, something that I find helpful or meaningful. And when I draw up the medication, I'm keeping that person in my mind at that point, because there are times when I may not have seen the patient for 6 months or more, and so I bring that patient back to me. And then, as the rabbi commented, for me, it's important that once I have administered the final medication, I do take a moment to acknowledge the relationship that I have had with this patient whose life I have just ended. Thank you.
That was great and a lot of information. I'm just going to stand up and stretch, but I'm going to sit down. I don't know if anyone else needs to stand up for a sec. So I'm just going to tell you a little bit about what happened with my father's MAID death. The story starts in a tiny oncologist office where my mother, father, and I sat as my father received his final prognosis, which was not a year, but more than 3 months. And at that moment, my mother tried to negotiate with the doctor, but my dad interrupted and cut to the chase and said, I'm thinking about MAID. He knew what he wanted. That launched a parade of lasts, which is quite a common experience for people who apply for MAID, where the decision creates this opportunity for all kinds of lasts. And the next last was my mom and I sitting in the rabbi's office here. We had just purchased a plot for my dad, and the rabbi was talking about death and death rituals, and my head took me to the graveside where I was imagining that initial thwack when the first dirt hits the coffin, and all of a sudden I hear my mother say, David's considering MAID. We had just purchased the plots for my mom and dad, and I thought, I have no idea what Jewish law says about MAID. Are they going to refund us the money? I don't know if he's going to be able to be buried. And the rabbi looked at us and said, I can be there if you want. And at the end of the day, that small act of kindness made all the difference in my dad's death. MAID is a medical procedure, as Dr. Jyothi just said, but it can also be a really healing rite of passage. And I'm actually writing a reported memoir about my dad's death, and I've heard dozens and dozens of MAID stories. And I've looked at lots of research around MAID, and there's direct correlation with grief and bereavement outcomes when you accompany MAID with ritual and ceremony. But when you're planning a MAID death, it's so bureaucratic, and it is a medical procedure and also, as you said, a legal procedure, and you can get caught up in that. And kind of the last thing you're thinking about is what ritual and ceremony you might add to the event. Rituals, we know, slow time, they're like a meditation, they cause you to pay attention, and they can be very healing. And that's what happened with us. When the rabbi came, he came before the MAID practitioner came to the house, and he told us he was very, very prescriptive. And there were 11 of us, my mother and my father, obviously, who was dying, my brother, our 6 children, and our spouses. And the rabbi came and he said, okay, when the MAID provider gets here, they're going to have to do a little bit of medical procedure to insert the IV. I'm going to take you downstairs. We're going to say a few things, and then we'll come back up. And so exactly that happened. The MAID practitioner arrived, and her team, because they usually come with a team, somebody usually has to put the IV in, and that's often not the MAID provider themselves. And the rabbi took us downstairs and said a few prayers, and then he said, okay, you've all had a chance to say goodbye, but now I need you to go upstairs and say your final goodbyes. I can't tell you how valuable it was for me personally to have that prescriptive approach from the rabbi. I tend to be kind of the dance step caller in our family. And he gave me permission to just be the daughter in that moment. I didn't have to be a wife. I didn't have to be a mother. I didn't even have to be a daughter to my mother in that moment. I just got to be my father's daughter because the rabbi took the space. He took the role of caring for all of us. And so we went upstairs, and one at a time, each of us had a chance to say a final goodbye to my dad. Personally, I told him, I love you, I'm grateful for you, and I forgive you, because all relationships are complicated. And I had that whole parade of laughs to mitigate all the regrets that I'd had, to say all the things I wanted to say, and to come to the conclusion that, yes, I forgive you, Dad, for any way that you've trespassed on me. And he, of course, said, there's nothing to forgive you for. The death was beautiful. 11 of us crowded around my father. We each held on to each other and to him. And time really did slow in those 6 or 8 minutes that it took him to die. I didn't notice the moment he passed. There wasn't, for me, a moment. It wasn't until the MAID practitioner pulled out her stethoscope and put it on my father's chest that I realized, okay, he's gone. But when I did realize that, I can tell you I was flooded by this, not grief in that moment, that would come later, but this incredible feeling of gratitude to live in a country where we have a choice about the way we die. And what I've learned about MAID, and I think a very important distinction that I've learned, is MAID is not a decision. People are not choosing to die. They're choosing how to die. People who choose MAID either have a terminal illness or they're suffering so completely that they can't live. So they're not choosing to die. They're choosing how to die. So I'm grateful to live in this country that allows people that choice. I was incredibly grateful for the rabbi and the MAID provider who both provided such compassionate care to us. And then, of course, to my courageous dad who made this choice that let us say a proper goodbye. I think that's my story. I would just say I've always believed that Jews do death best. I think we have an amazing process. And the fact that these rabbis are willing to attend a MAID death makes it just even better. So, thank you.
Thank you so much to everyone. That was really, really powerful and informative. We have about 20 minutes or so for some questions. So I'll open it to the group.
One more thing.
Sure.
Sorry. I just want to say one more thing. I think that MAID deaths can often be accompanied by shame and stigma. People sometimes don't want to share the way that their loved ones died. And that was another gift that the rabbi gave us, because by validating my father's choice, when people said silly things, and people say silly things when people die because they don't know what to say, I knew in my heart that the choice he had made was okay, and I didn't have to feel any shame about it.
One often hears that people are offered MAID, they turn it down a few times, and then when they finally want it, it's too late. Now, what do they mean by that?
I'm not exactly sure. The only thing I can think of is that if they have not signed a waiver of final consent, by the time they say, I want MAID, by the time everything can come together, because it takes 24 to 48 hours to put it together, to get the nurse, to get the medications. There are 2 pharmacies in the whole of Vancouver which will dispense the medication. And they are closed on Sundays and stat holidays. So if the person says, I want it, but they haven't signed a waiver, then by the time we can make it happen, they may no longer have capacity. That's one thing I can think of. The other is dementia. If someone has dementia and they have crossed into, but then it would be hard for me to imagine that they would say they would want it. So that's, it's not clear, but it's probably something like that, that they lost capacity. Because MAID is a medico-legal procedure. And so the pharmacists perhaps just can't be bothered. There's paperwork. The prescription is 7 pages long. And so we have to fax it to, there is an oversight committee of the ministry, which we have to fax it to. And they are very sharp. They call you on everything. And so I think pharmacists are busy. And so they just don't bother about it. And we've got used to having these 2. We've tried to include others, and they've come halfway and then just backed off.
Hi. One of you mentioned, I think it was you, Rabbi Brown, what do you do when there's a possible undiagnosed depression? As a therapist and as a human being, I'm interested in that, and that may be playing into the decision. How do you determine that, and what happens with that possibility?
So the assessor, this is a very important part of what we do. We have to assess the patient's mental health as well, and sometimes a person can have controlled depression, or it is a normal reaction to their diagnosis. It doesn't mean that it's pathological. Depression becomes important if it's affecting the capacity to make a decision. So when you're really depressed, you catastrophize. You don't see the world as it is. So it is our role to understand. So just being depressed is not sufficient to make you ineligible, but we definitely make sure that we understand what the circumstances are. So that's the assessor's role.
And from the Jewish standpoint, from the Reform Response Committee, was that depression is not a qualifying category for MAID.
And it's not not legally so either. Right now, mental illness alone, so having depression and ovarian cancer doesn't mean you can't have MAID, unless the depression is making you, your judgment, it's marring your judgment. But if you only had depression, right now, it's not legal in Canada to be eligible for MAID.
So some of you may know that my late husband, Ted, had ALS and chose MAID. He was diagnosed in 2019, and at the time of his diagnosis, he said, I want MAID. We were able to delay him till 2 years later when symptoms were really bad. He didn't want anybody to know it, so forgive me, Ted. But I would have shared it because I thought it was important. So at the time that he actually chose his final and actual date of MAID, it was the third time we had been able to persuade him to postpone. It was not sanctioned positively by Reform Judaism, so he didn't get the kind of blessing I would have liked for him to have, but he was ready. It didn't matter. I missed it, though. So I'm so thankful to Reform Judaism for recognizing that it can be very meaningful and that we've progressed to that. Thank you.
Thank you. My name is Martha, and my dad also chose MAID last year, and I just first of all wanted to just say thank you because I wasn't really sure how I felt about the program, and like I really understand what you said about very often the family is not pushing for it, but trying to hold it back because it feels so scary, and because we're not in the person's body, we don't know how they're suffering. And if anything, I regret not listening to how much he was suffering. And Kelley, thank you so much for sharing your story. Our experience was very similar. It was really beautiful. And my dad had a Jewish soul, but was anti-religious. But he was like reciting the book of Job in Hebrew and singing in Hebrew. And some of his brothers were able to be there too, including an Orthodox brother who really opposed it, but even he has like changed, being part of it has changed the way he looks at it. And I think one thing we came to later, first of all, we felt that the two doctors we saw was Ellen Weeb, and I can't remember the other doctor, but they spent so much time with us, the family too, and they made us feel included, and they embraced the rituals that we had, and that I really like the idea that we can talk about it and not make it something that we have to like add as an afterthought or explain it or give context to it, because the person was already, and my dad's, what he said in the end was like, I exist, but I am not alive. I am not living. So that really helped. And yeah, it was to the extent that someone can have a beautiful death, it was a beautiful death, and we all got to hold on to him and then to sit with his body for a while when more brother came up from Los Angeles to be with him too. And one thing my sister said later that I found really helpful was she wanted a natural birth, but she ended up having to have a lot of medical intervention when my niece was born. And she said maybe like she saw a parallel that we think people should just have a beautiful natural death, but if that's not possible, who are we to, like, there's not something better about having given birth naturally than to have needed medical intervention. So I don't know if that has ever come up for any of you or it's something you've reflected on, but I just wanted to share that. And like you, Kelley, I'm so grateful that this exists in Canada. And yeah, thank you so much for sharing, everybody.
Thanks so much for that. I just wanted to say one more thing about, so I volunteer for an organization called MAID Family Support Society, and if anyone has someone experiencing MAID or has had a MAID death and they're having trouble with grief and bereavement, this organization offers peer-to-peer counseling. But from what I've seen from the many people I've counseled as a peer, is that often the person is done. That's often the term they'll use. And I think they don't think through what ritual they might want because they are just done. And so I would counsel people who are family members to think about adding, whether you use the rabbinical service here or a death doula or someone else, including some kind of ritual and encouraging your person that that's what you need from their death.
First of all, thank you, rabbis and Dr. and Kelley and various attendees for such a profound level of sharing. It's very moving. I have a question about approach. I recently had an experience of somebody who was very, very ill, to die soon, and I wondered if they had considered MAID, but I didn't feel it was my place to ask them. And as it turns out, it would have been helpful had I been able to bring it up to the people involved, because it was ultimately information that they decided to seek. And I wondered if anybody on the panel had some advice for an appropriate way to approach the question with people.
Yeah, please.
So even as physicians, for instance, as a family doctor, if I confront somebody, I mean, I'm looking after somebody, I'm no longer in family practice, but let's say a patient comes in and we have a goals of care conversation, and if they start to tell me, you know, I just don't want to suffer, if something happens to me, I hope it's quick, and then it is my responsibility to make them aware that MAID is legal in Canada. And in many cases, we've actually incorporated that. So there are practices, and even in hospitals, we tread a fine line here because some people are offended when you mention MAID. On the other hand, other people would benefit from knowing that it exists. As a friend, I think it would depend on whether the person says, I am suffering so much, I wish there was a way that this could be shortened. I think then it is appropriate to say, depending on your relationship, it would be appropriate to say, well, are you saying you wish you could die sooner? Because you know in Canada, MAID is legal, and leaving it at that, not putting any pressure, but just telling them that the information is there.
There's a risk involved in bringing this up with a family member or friend if it hasn't been brought up before and you don't know where this person is. The question is, are you going to take that risk? If you feel that this is not something that you're pushing, but it's rather an option. And you may be thanked or you may be cursed, at which time you should consider the rabbinate. I mentioned that I had contacted the funeral director beforehand. We happened to have the Rosh, the head of the Chevra Kadisha, here today, and I haven't asked her this, but Kathy, has the Chevra Kadisha considered this?
I know that Rabbi Brown has talked about the reform responsa to MAID. The Vancouver Chevra Kadisha is under the auspices of the Orthodox Synagogue, Sharet Tzedek, and Rabbi Rosenblatt is our authority. While he would not like to talk about MAID, we at the Chevra Kadisha have prepared many bodies already of people who have died with medically assisted death. No Jew goes without preparation by the Chevra Kadisha at the time of death. So it's not a question for us.
Thank you, Kathy. I want to add one thing to Barbara's question about conversations about MAID, which is a bigger topic of not just MAID, but just choices for end-of-life care. Dr. Jyothi talked about DNRs and things like that. And, we as rabbis, we're really strong advocates of having those conversations, specifically among family members. I know if it's a friend, it's a little bit more complicated, but to be open and in dialogue about wishes for care and end of life and all of these things, it's a true blessing to be able to have those conversations openly. If we as a clergy team can help to assist in thinking about those conversations, we're really happy to be able to do that. I think we have time for one more question, Annika.
I think the Vancouver Coastal Health do make them. I happen to have been on 2 boards of assisted livings, and we have those posted in information, so people do have a choice to seek out more information. Am I correct that it's Vancouver Coastal Health? Yeah, okay.
Not just Vancouver, from Fraser, all the Fraser Health, everybody has these brochures in different languages too.
So thank you again, everyone, so much for attending and for this really very meaningful and profound conversation. We hope that everyone has a good rest of the day, get home safely, and we'll see you for our next Shishim program, if not before. Estelle, do you have an announcement? Is this a recommendation? One more. Estelle has a recommendation of a book called Being Mortal by Atul Gawande. So it sounds very good. Thank you all very much.
I thought I was going first. And
I'm curious what you think about MAID for mental health.
thank you. And may I